Hello everyone, my name is Dr. Vedant.murkey and today we'll be talking about the pupil. So pupil basically is the shutter of the eye, okay? जैसे कैमरा में you have a shutter जिससे light enter होता है. Similarly in the eye we have a pupil through which the light enters and hits the retina, and that's how we see. Pupil is as important as other structures of the eye like cornea and retina, because if the position of pupil is wrong, the shape, size, anything is not perfect, the image will not be very clear. So let's peek into the pupil. We'll approach this topic under these headings. So first we'll study about the normal pupil, the anatomy, the physiology, that is the pupillary reflexes, and with that we'll also cover the applied aspects of the same so that the MCQs are covered along with it. Next we'll know what is normal. Next we'll go to what is abnormal pupil, and then we'll go to Horner syndrome, which is again an abnormal pupil, but we need to consider it as a different entity because it's a bit complex and different when it comes to comparing it with other abnormal pupils. Then we'll study about anisocoria, light near dissociation, which will be covered along with these points in the earlier ones what I have told you. And finally question and answers. Now these will be covered along with every subheading which I have told you. Okay, so now let's begin. Okay, so first we come to what we call as shape of the pupil. Okay, so as you all know, normally the shape of the pupil is circular. Okay, let me increase the size. Okay, so normally it is circular. So all the other shapes apart from this are abnormal shapes. Very important, we'll consider all of them. Number one is known as coloboma. Okay, now what is coloboma? Coloboma is a congenital abnormal embryological development of the eye. Remember these terms: congenital abnormal embryological development of the eye. Why does this happen? The basic reason is it's a failure or incomplete closure of the optic fissure. Again, failure or incomplete closure of optic fissure. Basically this is responsible for proper shape as well as structure of the eye. So if it closes incompletely, we'll get what we call as coloboma. I'll show you the figure in just 1 second. Okay, so see this. As you can see, this is the coloboma. Okay, so due to incomplete closure, there is a gap in this pupil inferiorly. Most common site of coloboma is always inferior. So this is known as coloboma. Okay, let's move on ahead. Number two is aniridia. As you can figure out, an means an is known as absence. Aniridia is iris. So aniridia is absence of iris, which can be complete absence or incomplete absence. So it can be a complete aniridia or incomplete aniridia. Okay, so again aniridia is again having three more subtypes. A is isolated, that is there are no systemic features in the patient. The patient only has an eye with incomplete or complete loss of iris tissue. So majority of cases are these, inherited as autosomal dominant, and the gene involved is PAX6 on chromosome 11p13. Remember, this is just a small deletion or mutation of the gene on this chromosome. But what will happen if this deletion or mutation is vast, or you can say a bit larger? So it will involve the gene which is adjacent to it, that is the WT1 gene will be involved, and that's when we get what is known as WAGR, which is known as Wagner syndrome. Why do we call it WAGR? It's very easy. W stands for Wilms tumor, A stands for aniridia, G stands for genitourinary abnormality, and R stands for retardation, that is mental retardation. ओके, सो आइसोलेटेड, अगर डिलीशन थोड़ा ज़्यादा हो जाता है तो WT1 जीन इन्वॉल्व हो जाता है एंड यू गेट WAGR syndrome, that is WT1. Now, the next what I call is again high yield point is what you should remember as Gillespie syndrome. So this is a high yield point. Gillespie syndrome is a very rare condition. It is autosomal recessive. Just one second. Yeah, it is autosomal recessive and it is a combination of aniridia plus cerebellar ataxia with mental retardation. Okay, so remember this, I remember it as AMC, जो हमारे machines का आता है, annual maintenance contract. Ataxia, mental retardation with cerebellar, sorry, aniridia, mental retardation with cerebellar ataxia. Fine. Now we covered two, that is coloboma and aniridia. Now we move on to the third, which is blunt trauma leading to tear of sphincter pupillae. Okay, जब भी trauma होता है आंखों में, so there are many other manifestations which will point towards blunt trauma, but one of it can be damage to the sphincter of the eye and we get a tear, so the perfect circular shape becomes a bit abnormal. I'll show you how. Let's have a look. Yes, so this second figure, as you can see here, is aniridia. The iris structure, this is not a dilated picture. Okay, you will have a good history around question if you get this figure. So this is aniridia. This is a partial loss of iris tissue, as you can see a thin rim around. Okay, over here. So this is partial aniridia. If I focus over here, if you can see this is a partial tear in the sphincter pupillae, and that's why it is not a perfectly circular shape. There is a notch. You get it? Okay. The next very important is number 4, which we call as iridodialysis. Okay, irido means irises. Dialysis, don't think of renal dialysis. Dialysis here means detachment of iris from its root, that is ciliary body, CB, that is ciliary body. So whenever iris gets detached from the root, we get something known as iridodialysis, and the shape of the pupil classically defined as D-shaped pupil. अभी देखते हैं D-shaped pupil कैसे और क्यों मिलता है. The most common cause, can you guess? Very simple, is trauma. अगर बहुत forcefully trauma होता है तो iris सीधा निकल जाएगा उसके insertion से, root of insertion, which is the ciliary body, and it can be also caused due to surgical trauma. If surgery is not very meticulous, there's a lot of manipulation inside the eye, the iris gets detached from the root. Very common step of cataract surgery where this iridodialysis happens is vectis delivery of nucleus in cataract surgery. Remember, again, this is a high yield. You can note this. Okay, now let's have a look at how does it look. As you can see, okay, so this was the root at which iris was attached. Now due to trauma or any other reason, it got detached and came here. So now you get a D-shaped pupil. This is laterally inverted D. If it goes off from here, you will get a pupil like this. Okay. Oh, fine. So this is known as iridodialysis. The next we move on to is what is known as festooned pupil. So when do we get festooned pupil? It classically occurs in cases of intraocular inflammation. What can be the reason of intraocular inflammation? The most common site of inflammation inside the eye is the uveal tissue. So uveitis, if I have to be specific about uveitis, I would label it as anterior uveitis. Okay, so anterior uveitis will cause something known as festooned pupil. But why? So what happens is, in anterior uveitis, what we get is known as posterior synecdoche. Okay, so suppose this is the lens attached from the ciliary body. Also, this is the iris. Okay, this is the cornea. Very rough figure, just try to understand. So what happens is, during inflammation, there is a lot of reaction in the anterior chamber. This is all reaction in the anterior and posterior chamber. This iris will go and stick to the anterior surface of the lens. Okay, so anything जो भी चिपका हुआ है, it's very tough to break it by drugs or any other means from outside. If you go inside and break it with a spatula, it's okay. But when you put a dilating drop, so the circular pupil, it is all stuck here, 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 posteriorly, इसके पीछे. So when you put drops, this will dilate, this will dilate, this part will dilate, this part will dilate, but this won't. So हमें मिलेगा कुछ ऐसा figure. Okay, this is known as festooned pupil. I'll show you the figure. See this. So these are the site of attachments जहाँ पे synecdoche हुए थे. Okay, sorry, not this. Yeah. So this is known as festooned pupil because यहाँ से ये dilate नहीं हुआ, it is stuck to the anterior surface of the lens. Okay. Now, having done 5 types, a very rare, again, it's a high yield point, is known as tadpole pupil. Okay. Remember just the name, tadpole pupil. So what is tadpole pupil? Tadpole pupil is episodic focal spasmic contraction of dilator muscle of pupil. Just remember this is known as tadpole pupil. This is a high yield. You might get an exam or you might not get an exam. It's very, very, very rare. Okay. So now we have dealt with the, what did we see? The shape of the pupil. The next we deal is with the position of the pupil. As you can see over here, just 1 second. I hope this is visible. Yeah. We deal with position, number, size and symmetry. Okay. So what do you think should be the ideal position of the pupil? Position of the pupil. Not the shape, position. Yes, it should be central, ideally. But remember, in body nothing is ideal. The perfect position of pupil is slightly inferonasal in all the cases. It is a normal position of the pupil. So if you get an option which is inferonasal, choose this, because this is the, now how much inferonasal? Remember, it is 0.7 mm inferior, 1 mm nasal. So less than equal to 0.7 mm inferior and less than equal to 1 mm nasally. More than this, the pupil position is abnormal. Okay. Now, having said the normal position of pupil, what does an abnormal position of pupil called as? It is known as chorectopia. Okay, chorectopia. Now, since we know what is abnormal position of pupil, we should also know the causes. Remember the mnemonic, ice spot. Okay, so ice and spot. Just underline the way I have underlined, because I'll tell you why. The first cause is ice syndrome, which is also known as iridocorneal endothelial syndrome. Okay. The second cause is chronic uveitis. Okay. The third cause is ectopia lentis at pupillae, and the fourth cause is post operative, and T stands for trauma. Okay, so remember, eye spot, eye syndrome, chronic uveitis, ectopia lentis at pupillae, post-operative, and trauma. What is eye syndrome? Just try to understand the concept. It is iridocorneal endothelial syndrome. The epithelium of the cornea grows inside, covers the endothelium. This is known as iridocorneal endothelial syndrome. इस वजह से there is a pull on the iris, so the position shifts. Okay, remember this. Now we'll move to something known as the next parameter or the next point, which is the number. So what is the normal number of pupil in each eye? Obviously you will say it is 1, which is right. So any number which is more than 1, is that possible? Yes, is that possible? It is possible. It is known as polychoria. Remember, it is known as polychoria. More than 1 pupil in one eye is polychoria. Again, polychoria can be a true polychoria or a pseudo or false polychoria. So when we say true polychoria, it is very rare condition. That is, embryologically development ऐसा हुआ है that there is more than 1 pupil. It's very rare. False polychoria, again we can say it's not common, so we'll talk it as being less rare. Okay, so what are the causes you can think of? We saw one of it just earlier when we studied the shape of the pupil, this one, that is iridodialysis, because we got almost another opening in the eye. So iridodialysis is one of the cause. Okay, again eye syndrome is another cause. Juvenile glaucoma is the third cause, and posterior synecdoche. Remember these causes. Okay, these are the causes of pseudo or false polychoria. I'll show you the figure. Okay, just have a look over here. This is a true polychoria, perfectly circular, 2 openings in the iris, true polychoria. If you see here, this is a false polychoria because this part is not a true iris tissue. It's a posterior synecdoche, which is seen in uveitis, anterior uveitis. Okay, I'll zoom in more if you can see it more clearly. Fine. Now we have talked about the number. Now we'll move on to what we know as the size. Sorry. It's too small to be seen. Let's just erase it. Now we move on to the size. So remember, the average size is around 2 to 4 mm. This is the normal size of the pupil. Anything less than 2 mm or more than 4 mm, this is called as miotic pupil or meiosis. This is known as mydriatic pupil or mydriasis. Okay, remember these terms, meiosis and mydriasis. So first we will see the normal variation in the pupil sizes. So this range is common in adolescence. It's common in adolescents, adults, pardon me. This range is common in adults. Okay. Now what happens is pupil size is maximum during adolescence, as you can correlate it with increased sympathetic activity, hormonal changes. So this is in adolescence, either end of the spectrum, that is in very young age and in very old age. These are meiotic, very small in sizes. Why it is small in old age? It's a very interesting concept. As you can see that in old age there is a lot of sleepiness. They get tired very easily. So increased sleepiness reduces the inhibition of Edinger-Westphal nucleus. Now remember, I'll show you in the slides ahead that Edinger-Westphal nucleus is the parasympathetic nucleus of the cranial nerve 3, which supplies the sphincter pupillae. Now, if the inhibition from the cortex is less, it will fire more. If it is firing more, it will stimulate the sphincter pupillae more than the dilator pupillae. So that's why there will be decreased size of pupil. Okay, so this is a very interesting concept. I think we all should remember. Again, depending on the state of refraction of the eye, number कैसा है patient को. So remember, myopes will have a larger pupil than hypermetropes. Okay, this another point. So we'll see other causes. So these are the physiological or normal variation in the pupil. Sorry, it's stuck, I think. Yeah. So these are the normal physiological variations in the pupil size. Now we'll see causes of increased size of pupil and decreased size of pupil. That is, we are seeing causes of mydriasis and the causes of meiosis. Okay, fine. So there is one mnemonic which is available in books. I liked it a lot, so I'm using the same, which is known as big oats, and here you can remember it as hiccups. Okay, these two mnemonics are good enough to remember all the causes of mydriasis and meiosis respectively. So when I say big oats, B stands for belladonna poisoning, I stands for internal ophthalmoplegia. We'll study it more during neuroophthalm. G stands for glaucoma. More specifically, remember, angle closure glaucoma. Very important. Angle closure glaucoma causes mydriasis. Then we come to what is known as oculomotor palsy, which is very logical, because if there is a palsy of oculomotor nerve, that is cranial nerve 3, the sphincter pupillae will not be innervated in a efficient manner or will not be innervated at all, and that's why the dilator pupillae will act more and we'll get a mydriatic or a larger pupil. Then A stands for use of atropine, which is a mydriatic, so again it will cause, and other mydriatics I can say here. So all the mydriatic drugs like adrenaline, noradrenaline, phenylephrine, all of these will cause dilation of the pupil. Then we have tonic pupil, which we'll study again, which is an abnormal pupil, and S stands for sympathomimetics, which is nothing but mydriatics. Okay, fine. Now we come to what is known as meiosis. Again, it's a very good mnemonic which we call as hiccups. H stands for Horner syndrome, which we'll study ahead, and hemorrhage, to be very specific, is pontine hemorrhage. I had gotten a case scenario of pontine hemorrhage in my AIMS entrance, so remember this point. I stands for iridocyclitis. Again, very important. People confuse it that iridocyclitis is inflammation, so pupil will dilate. No, pupil gets meosed because there is a lot of inflammation causing release of prostaglandins, which is again an inflammatory mediator and which causes meiosis of the pupil. Then comes C, which is carbolic acid or clonidine. Okay. Then O stands for organophosphorus poisoning or opioids. Remember, OP is organophosphorus poisoning. OP is not of that game PUBG. This is OP, organophosphorus poisoning. Then we come to P, which is parasympathomimetics. Parasympathomimetics. Pilocarpine, again a parasympathomimetic, and a psychiatric drug which is phenothiazine. Okay, in sleep and with sedatives, you will get miotic pupil. Got it? So these are the causes of increased size, which is mydriasis, decreased size, which is meiosis. Please, I believe you have noted it down. Please have a look and please note it down here. Okay, you can take a screenshot as well. Fine. Now, let's move on to the last point, which is symmetry. Very important point. It seems कि इतना important नहीं रहेगा, क्या है इसमें symmetry है, एक कम एक ज़्यादा? No, it's very important. So remember always the two pupils of both the eyes are identical and symmetrical. Okay, if not, if one is bigger, one is smaller, the term is known as anisocoria. This is a different subheading altogether. Very important because clinically it points out to a lot of anomalies. You can detect a lot of anomalies in the sympathetic pathway. How? We'll see it later. So guys, we are done with the anatomy of the pupil, the normal anatomy, the abnormal anatomy. Okay. Moving on to what we know as physiology of the pupil. In physiology of the pupil, what we'll study is basically the reflexes. Okay. So let's have a look here. Okay. Yeah. So we'll study the light reflex, the accommodation reflex in detail. Remember these two reflexes, we'll finish it off here only. Ciliospinal means related something to the spinal cord over ciliary and ciliary region in the eye and spinal cord. Psychosensory reflex. So ciliospinal reflex is nothing but ipsilateral pupillary dilatation following any pain in the neck or upper trunk. Just remember this definition: ipsilateral pupillary dilatation following any pain in the neck or upper trunk. Psychosensory reflex is nothing but pupillary dilatation in response to stress, anxiety, because your sympathetic response is increasing in the entire body. You get sweating, you are frightened, your heartbeat increases and your pupils also dilate. So remember this. Now we'll study in detail what we call as light reflex and accommodation reflex. More important for you here would be the light reflex. When we talk of light reflex can be direct or other, as you can guess, indirect. But a better term than indirect is a consensual light reflex. Okay. So as the name suggests, this is a response of the pupil to light. Whenever you show any light or you put any light in the eye, how the pupil reacts is light reflex. Now, let's have a look at the pathway. So, for example, there is light you have shown into the pupil. From pupil, it enters in the eye, hits the retina, more specifically the photoreceptors, that is the rods and cones. Okay. So from there it travels to the optic nerve. Through the optic nerve it goes to optic chiasma. Remember now. Now optic chiasma is a very important structure in the visual pathway because, or the light reflex pathway, because here nasal fibers, the fibers which arise from the nasal half of your eye or the retina, will decussate. Decussate means they will cross, and the temporal fibers will go uncrossed. Okay. So high yield point, the ratio of crossed to uncrossed fiber is 57.43%. Just if it interests you to remember, you can. If you want to forget, please forget it. So the nasal fibers will decussate or cross to the other side and the temporal will travel through the same side. Now we have something known as optic tract. Okay. So the optic tract will have fibers, nasal half from the opposite side and temporal half from the same side. Okay, got it? Because they have crossed at the optic chiasma. From here it will go to something known as pretectal nucleus. This chart is very important because many MCQs will be covered in here. So be very attentive when I talk about this light reflex. many MCQs will be covered. This pretectal nucleus is at the level of superior colliculus. Don't confuse. Superior colliculus के level पे there is pretectal nucleus, which is the site of vision center. Not exactly vision center, but it is related to eye. Just remember, it is related to eye because inferior colliculus is related to ear. Don't confuse this. So this is present in midbrain at the level of superior colliculus. Very important, the pathway. Now there are two pretectal nuclei for each eye. From each nucleus, fibers go to the same as well as opposite side. I'll just label it with another. Okay, so same and opposite side. Okay, so these are known as internuncial neurons or fibers. Now, where do they go? They are going ahead to nuclei, which is the center of parasympathetic activity, that is Edinger-Westphal nucleus, EWN. Okay, so this pretectal nucleus, one pretectal nucleus innervates both the Edinger-Westphal nucleus, and now this is the reason why we get consensual or indirect light reflex. How? Just follow me, you will realize it. Okay, now take any one Edinger-Westphal nucleus, we'll track any one, is the same for other. It will go, the fibers, parasympathetic fibers will go to, I'll write PS, parasympathetic fibers will go to something known as ciliary ganglion. Remember, ciliary ganglion is located in the cone of orbit, or specifically muscle cone of orbit, between the optic nerve and medial rectus. Okay, remember this, very important. This is the new ganglion which will block in peri or retrobulbar anesthesia. Remember, very important, high yield points. Now, from ciliary ganglion, what happens at the ciliary ganglion? Remember, all parasympathetic system, the entire parasympathetic system in our body, the ganglions are present near the target organs. For sympathetic system, the ganglia are present near the spinal cord. This is a rule for the entire body. So this is a ganglion, this is a parasympathetic ganglion for the eye. So here, the fibers which originate from the Edinger-Westphal nucleus, the parasympathetic fibers, these will undergo synapses, which is, it will synapse here, and through the nerve which is known as short ciliary nerve. Remember, it is a short ciliary nerve. It will innervate sphincter pupillae. Now, this Edinger-Westphal nucleus got impulse from both the ends. Okay, and both the nuclei are stimulated simultaneously. So this is the reason why we get the consensual or indirect light reflex. What do I mean by that? Is when you throw light in the right eye, the right pupil will constrict because sphincter pupillae has been stimulated. Also the left will constrict. So the constriction of the right, when you throw the light in the right eye, is known as direct reflex, and the constriction of the left when you throw the light in the right eye, that is the other eye, is the consensual or indirect light reflex. Okay, now very important to remember, again one more point, is how does this fiber reach ciliary ganglion? I showed you directly parasympathetic fibers well enough, but for high yield point, remember, cranial nerve 3 originates from Edinger-Westphal nucleus, its branch, which is a branch to inferior oblique. The fibers which also supply inferior oblique through cranial nerve 3, it carries the parasympathetic fibers. So the question comes like, which nerve carries the parasympathetic fibers to sphincter pupillae to the ciliary ganglion? The answer is cranial nerve 3, but more specific, branch to inferior oblique of cranial nerve 3. I hope you are clear with the light reflex. If you don't understand anything here, you won't be able to get anything about the abnormal pupils, which we will be talking in the section ahead. Now, having seen this, we will move to what is known as accommodation reflex. Okay, reflex. Now, when we talk of accommodation reflex, remember again, we remember it as AMC, that is, it is a triad of accommodation, meiosis and convergence. Remember AMC, accommodation, meiosis and convergence. It is a triad. Number 1. Number 2, the stimulus for this is shift of target from distance to near. And number 3, very important to note, is vision is not a prerequisite. Vision is not a prerequisite for accommodation reflex. Very important to remember. Okay. Now, let's look at how does this reflex. Very important, one more point I forgot, sorry, is number 4, the center for near reflex is ill-defined. Still we do not know what is the center for accommodation reflex, because what we predict is it just lies a bit ventral to the light reflex center. First we'll see at the reflex pathway. Okay, so this is the accommodation reflex pathway. So you have the stimulus is, there is a distant target, suddenly you have moved it to the near. So from the eye, the impulse goes through the same until optic tract, same pathway until optic tract. From here, it will not go to the pretectal nucleus. It will go to something known as lateral geniculate body. Remember this, lateral geniculate body is involved in accommodation reflex. Okay. So this is involved in accommodation reflex. It will go to optic radiation. Optic radiation will carry it ahead to the visual cortex, that is area 17. Again an MCQ here, visual cortex is area 17. Frontal eye field, it will go to frontal eye field, which is known as area 8. Okay. Now from the cortex, that is the brain, fibers will come down again to the midbrain, go to the Edinger-Westphal nucleus, which is the nucleus of cranial nerve 3, and also the somatic motor nucleus of cranial nerve 3. These are ill-defined centers, as I told you earlier. Again, cranial nerve 3, Edinger-Westphal nucleus will go to ciliary ganglion. How does it go? Through the nerve of inferior oblique. Short ciliary nerve, again the same pathway. Contraction of constriction pupillae, again the same pathway as I told you, and you are getting constriction of pupil. This is very much similar to light reflex, but the only thing is it is going through the lateral geniculate body. Now, short ciliary nerve will also supply the ciliary muscle. There will be contraction of the ciliary muscles. When the ciliary body contracts, the zonules relax. When the zonules relax, the lens swells up and the anterior curvature of lens increases, which causes the rays to focus on the retina effectively. Okay, so this is the contraction of ciliary muscle and increase in anterior curvature of lens, which is also termed as accommodation. Okay. The somatic motor nucleus. Motor nucleus is nothing but the stimulus to muscle, that is the medial rectus. Both the medial recti will contract and eyeballs will turn inside, that is converge. This is very important. So this is near reflex. Okay, this is near reflex, and the triad is known as accommodation reflex. Why is this important? I'll show you. Very important to note again is light reflex present near reflex absent, light reflex absent, near reflex present. Okay. Near reflex is absent, light reflex is present. Is it possible? Remember, this can never ever be possible. Okay, but this can be possible. Why? Because near reflex center lies a bit ventral to light reflex center. So therefore most of the dorsal lesions like pinealoma, remember this, very important, will affect the light reflex center and spare the near reflex center. Okay, let's have a look. Okay, so this is the pretectal nucleus. Okay, this is more dorsal. This is the near reflex accommodation reflex center, which is more ventral. Pinealoma will affect this center, classically sparing this. So near reflex will be present, light reflex will be absent. Why is it important? Because clinically you might not be able to see such clear demarcation, but if you do make out that near reflex or accommodation reflex is greater than light reflex, what do we talk about here? Is pupillary constriction. So you watch the pupillary constriction. If it is more in near or accommodation reflex than light reflex, investigate the case. There's something wrong. This is a catch point. There's something wrong in the CNS, the central nervous system. You have to investigate the case. Okay. So this is it about the normal pupil. We'll take a break over here and we'll move on to the abnormal pupils in the next session. Thank you so much. If you want to reach out to me and ask any queries, leave any feedback, please feel free and drop me a mail on vedant.murkey@gmail.com. I'll see you around soon. Thank you so much for listening, and please do rate my teaching and let me know any improvements, any suggestions, any modifications you need or you would suggest in the way I teach. Thank you so much. It's been a pleasure.